Thank you. So big thank you to Dave. Thank you to everyone for joining today. My presentation is going to be covering the role of the Drug Access Navigator, what they do to help in the oncology clinics, what they can do to help patients, and all of the reimbursement opportunities in Ontario, as well as across Canada. So my presentation is focusing mostly on what a drug access navigator is and what they do and how they help patients every day. So this is the agenda. We're going to start off with what the definition of a navigator is, what they do all day long as part of the healthcare team. Not everyone is aware that they're actually in every hospital in Ontario. There's always times where somebody might slip through the cracks and not be referred to their navigator, but they are there. So to make sure you ask for one. We'll talk about some of the Ontario drug reimbursement sources in better clarity. So things like Cancer Care Ontario, the Ontario Drug Benefit, and the Community Care Access Centres. And then in complement to those, there's other funding sources that are applicable to all of Canada. So it doesn't matter what province you're in. That would be things like private insurance plans, patient support programs, clinical trials, and the special access program from Health Canada. And then just a little bit to wrap up with some of the challenges that are involved with all of these different funding sources. And then I have just a little word about National Pharmacare, which is also popping up in the news periodically. So Dave introduced me, but just to refresh, I was the drug access navigator at North York General Hospital for quite a while. So I only just recently left to join Centrex. So I still consider myself a hospital employee. You know, I only left just a couple months ago, so everything is still very fresh. But in my new role, I'm actually creating those patient support programs that maybe you're involved with. So programs like RevAid and OnePath, those are different drug companies, patient support programs. So I'm actually helping to build those to help patients. So the navigator role, which there are at least 70 now in Ontario, when I became a navigator a decade ago, there was only a handful. So it's definitely expanded quickly. Some people wonder who's paying for these people and where's the money coming from? That's one of the questions we got a lot. They are all employed by hospitals. So when you go to the cancer clinic and you see your nurse and you see your hematologist, if you see a navigator there as well, they all get paid out of that same budget. They're just like the dietitian or just like the social worker. They're publicly employed, so they're not private sector people who are in the hospital. They're just as trustworthy as your nurse and as the social worker. So the role started probably about 15 years ago in Ontario. But since then, as you can see there, it has grown to nearly 100 just in Ontario. And there's probably another 50 outside of Ontario. So Ontario kind of led the way, but there are navigators in Quebec and British Columbia, Alberta. They're found all across Canada. And because the role started organically, it was not something you go to school to learn about. Each hospital just decided who would be filling that role. So every technician or every navigator has a different background. Most of them are pharmacy technicians because they go to school to learn about medications. But some of them are social workers, some of them are secretaries, some of them are nurses, and some of them are pharmacists. So you get a very wide variety of backgrounds for the people who are doing this role. And some of the hospitals don't call them drug access navigators or DANs. They're called drug access coordinators, medication reimbursement specialists at Princess Margaret. So there's different words and titles for this same role, but ultimately their goal is the same. It's to help people get through the reimbursement system. So they're all doing the same thing no matter what they're called. So the navigator works directly with the oncologist and the hematologist in the clinic. So what will happen, the flow of things is typically the hematologist will know who's coming up next in their attendance list, and they can go over to the navigator and say, I'm looking at getting Darzalex for this patient. Is that going to be possible? Or I just went to a conference on the weekend and I heard there's this brand new medication for myeloma. How can we get it? So that's kind of half of it. That allows the navigator to see, is there a program available? Is it publicly reimbursed? We can do some preliminary work to see how we can access this medication. Or the doctor will say, well, I've just seen this patient and I want to get them Kyprolis, right? So it can be either a little bit proactive, which we appreciate, getting a little bit of time to look things up, or it might be after you've seen the hematologist. They might say, okay, now let's go see the navigator and see if we can get that treatment set up for you. So the reason why they do that is because there's so many drugs in cancer care. In myeloma especially, it's really taken off in the past couple of years, not necessarily even new drugs, but combinations of drugs. So you have a drug that comes out, it works very well on its own, and then they want to add it with Revlimid, or they want to add it with Velcade, and you get a whole bunch of combinations. And the way funding works is very restrictive, which we'll go into. So even though the doctor might want to do something and it will work, it will probably work, the government does not see it that way. So with payers like the government or private insurance, they typically will fall back on evidence. So there has to be clear evidence that a particular combination will work before they'll pay for it. So that's why they'll come to the navigator and say, this brand new thing, I want to try it out. Is there anything we can do? So it's not necessarily a clear-cut solution. It might not just be, you can go to the pharmacy and get it. It's going to involve a lot of coordinating between maybe different drug companies, different programs, and combined, hopefully, you won't end up paying anything for your medication. So this is kind of what the whole healthcare team looks like. And I know everyone is very familiar with their primary treater and their nurse, but there's a whole bunch of other people in the clinic. So the navigator is just part of that. You have your palliative care team, psychosocial support, the social worker, the dietitian. There's a whole bunch of other people who are involved with treatment. Medication reimbursement specialist is just one part of that whole puzzle, but they're equivalent, right? Like if you have any questions, there's usually a specialist as part of the treatment who can provide you with more information. Even if you don't need them right away, it's good to at least meet with them because they might be able to tell you things you didn't know you needed, right? So sometimes it's good just to sit down with a dietitian for advice, even though it might not be something you think you need. Then you talk to them and suddenly you have a lot of questions and it's changed your life. So it is good to talk to the whole spectrum of people who are on the healthcare team, like the reimbursement specialists. So we'll talk about the funding options in Ontario. So for the most part, these drugs are reimbursed when you are over 65. So most of the orals are covered when you turn 65. The IV therapies are covered no matter what your age is. But there's a lot of specific nuances and gaps in there that people sometimes are not completely aware of. It can cause a lot of frustration. So we'll start with the biggest funding body, and that's Cancer Care Ontario. So they fund the IV drugs for cancer only. That's all they do, cancer IV drugs. And they have two buckets of money where they can fund things. So there's one called the New Drug Funding Program, or NDFP, and the Evidence Building Program, or EBP. But don't worry about those. So ultimately, their primary focus, if you have OHIP, and there's a particular IV cancer drug, such as Darzalex or Kyprolis, then they would be typically the first ones to pay for that drug. But it's not that simple. So like I said before, they have criteria. The criteria for the government follows the evidence from clinical trials done on these medications, but the government is not so speedy. So we may have some brand new evidence presented, maybe in the United States, and someone like Donna Reese will go and hear this great new evidence, but it will be maybe 2 years or 3 years before the government starts to fund that same treatment. So even though the evidence is there, they don't do it so quickly to start paying for it. So that's why we'll end up with a new drug or a new treatment of multiple drugs together and the oncologists or the hematologists are asking for it, but the government will not pay for it. So that's why they're not paying for it. So you might have somebody who really needs Kyprolis with Revlimid and dexamethasone, and maybe the government will say no to that because it's not meeting their criteria. So their criteria, again, is it lags the evidence. They do update it, right? So there's the whole bunch of different cancer treatments that they do maintain myeloma as part of that. But it is definitely not as speedy as people would want it to be. The CCO funding is completely handled by the physician and your pharmacist. It's not something that you need to be involved with. You don't have to fill out any forms or anything like that for it. But it is helpful to see the CCO drug criteria. It is available on the internet. So if you ever are looking at a particular treatment, maybe you were told it was not funded, or you want to see if a type of treatment is funded on your own, it is on the internet. So if you go to the CCO formulary on their website, you can enter a drug and you can see the criteria. So the same criteria that your doctor sees, you can see it as well. And you can see in the criteria a particular regimen maybe that you saw online, and it's not there in the list of criteria. And that might be why. It might be something that's not funded yet, but it could be coming in the future. So this is an example. If you go to the formulary and you look up a drug like Darzalex, you can see that there's the monograph. So that's just some information on the medication. And then the eligibility forms, that's where you can see the criteria. So in Ontario, for CCO to fund Darzalex, these are the only two options. It has to be given in combination with bortezomib and dexamethasone for relapsed multiple myeloma, or in combination with lenalidomide and dexamethasone for relapsed multiple myeloma. If you want to give it in another combination, it's not going to be funded. So there could be something theoretically like maybe instead of lenalidomide, you want to use the Darzalex with pomalidomide. So it might work and your doctor might want to use it, but the government does not recognize that combination and they'll say no, they won't pay for it. And you can see that again just by going to their formulary. So this is what the eligibility form itself looks like. I hope this isn't all refreshed for everybody, but this is exactly what they use in the healthcare hospitals. This is what your pharmacist and your doctor look at. When your doctor prescribes Darzalex for you, they fill this form out and they submit it to CCO. So you have to meet these criteria. So this is an example of the one where it said Darzalex given with bortezomib and dexamethasone. So let's say I want that regimen. So I have myeloma and I have a good performance status, but you have to have received at least one prior therapy. So that's another part of the criteria. If you want to use this in the first line setting, so if you want to use this combination of these three drugs as your first treatment, CCO will not fund it. So it has to be used after at least one therapy. So there's these types of criteria for all of the cancer drugs. For any of the IV drugs, any of the take-home cancer drugs, they all have these strict criteria that you can't deviate from. If you don't meet those criteria, the government just says no, you have to find something else. And this is typically what I think causes a lot of confusion. If somebody looks up a medication or a regimen on the internet, the brand new stuff from the FDA in the United States, and wants to do it here in Canada because it's this amazing treatment and it's very successful, that's why you probably can't get it right now. It doesn't meet those criteria. For now, it might meet the criteria. They might update the criteria in the future, but that's something you could advocate for and say, well, we need this sooner. We need this particular criteria changed. Even though you're funding Darzalex, you're not funding Darzalex for me because I need it in this particular use, right? So that's where it gets very muddy. So just like Cancer Care Ontario, the other drug funding body is the Ontario Drug Benefit. So this is where any of your blood pressure medications, any blood thinners, any diabetes medications, that's who's paying for all of those typically when you are over 65. So when you're over 65 and you have a lot of prescriptions and you take them to the pharmacy and you pay maybe $2 each or $6.11 for each drug, it's ODB, it's the Ontario Drug Benefit who's covering all of those pills. So the real cost is much, much higher, but they're just charging you a smaller copay instead. So they're covering the bulk from the government. And all you need to do to qualify for that is have OHIP. So it's for everybody. So there's the bulk of people who are using the Ontario Drug Benefit are over 65, but there's other ways of accessing that same coverage. So if you're living in a long-term care home, you can qualify for ODB. If you're under 24 years old without private insurance, you qualify for ODB. If you're receiving Ontario Works or the Ontario Disability Support Program, ODSP, you also qualify for ODB, so they're paying for your medications. And you can apply as well through the Trillium drug program. So you've probably heard Trillium, we're going to talk about that as well. All of these are different pathways of accessing the exact same thing. So if you're on Trillium or if you're 80 years old, you're getting the exact same Ontario drug benefit, that ODB coverage of 5,000 different drugs in Ontario. They're just different ways of getting access to that same funding mechanism. So there's some confusion that I really want to alleviate regarding take-home cancer drugs. And those are pills like Ninlaro or Revlimid. These take-home cancer drugs are paid for by ODB. So when you're over 65 and you go to the pharmacy with a prescription for Revlimid, as long as you've been put into the patient support program, you probably don't pay anything for that Revlimid, even though it's about $8,000 a month. You probably are maybe paying that $2. But if you're under 65 and you've applied to Trillium, you're also accessing that $5,000 and they'll also pay for that take-home cancer drug. So in the news, unfortunately, I see stories where people are saying that take-home cancer drugs are not paid for in Ontario. And I have many patients who are over 65, many patients who went on Trillium for their take-home cancer drugs who didn't pay anything for them because Trillium was paying for it or the Ontario Drug Benefit was paying for it. So it's very misleading to say that take-home cancer drugs are not paid for in Ontario. And when I see these articles in the Toronto Star and the National Post, there's breast cancer patients and kidney cancer patients who are paying for their take-home cancer drug out of pocket, paying the $6,000, $7,000 per month because they thought there was no way to get it paid for. If they had gone on to Trillium, they would have paid nothing for their medication. So it's quite harmful to say that Trillium does not cover these drugs. If you're over 65, you don't need to Trillium. It's only for people who are under, but it's there as a tool. And we're going to talk about it in more detail just to clarify, but it is very important that people who are under 65 know that there is a system of getting these take-home cancer drugs paid for. And you should not have to pay for it out of pocket. You just have to apply to Trillium. So the other part of the Ontario Drug Benefit, like Cancer Care Ontario, is the criteria. So the criteria for the cancer drugs fall under the Exceptional Access Program. So you may have heard of the EAP system, and EAP works in conjunction with ODB. So ODB pays for the drug, and EAP is kind of like a key that gets you access as long as you meet the criteria. So just like CCO, the EAP criteria is online. It's all publicly available, and you can look up any drug to see what the criteria is. And Corinne, you have a question?
Yeah, I wanted to know, is there an income requirement? Because I think that may be an issue.
Yes. So yeah,
So
that Trillium is next, don't worry.
Oh.
Yeah, so it is a little bit more complicated when you pay for drugs with Trillium than if you're over 65. It's not exactly the same, but it's not as burdensome as some people might think. So that's, I think, in just 2 more slides, don't worry.
Okay.
So just for any sort of take-home cancer drug, you can look the criteria up here on the EAP drug list. And you can see I was prescribed a particular drug. Is it going to be paid for by ODB if you're over 65 or going on to Trillium? And you can see the criteria is very strict. It's even more criteria than CCO does. It's for a drug like Revlimid, it's several pages long of criteria. And all of those criteria have to be met for the government to pay for it. So you might be prescribed Revlimid, or your doctor would love to give you Revlimid, but if you're not strictly meeting that criteria, then it's not going to be funded. So this is an example of what it looks like for Revlimid. And this is, again, freely available on the internet. So if I look up Revlimid, do I meet all the criteria for it to be paid for? And if any of these are a no, then it cannot be funded by the government, which will bring us to other funding sources, which we'll get into. But for the most part, if you can get a drug and it's covered by the government, it's going to be the least amount of hoops to jump through. So again, these are also updated very frequently. What is not funded today could be funded in a month, or it could be funded next year, or never funded. There are drugs that never come to Canada. There are drugs that the criteria, it doesn't matter. It's just the particular drug manufacturer, you might already know this, but sometimes they don't bring therapies to Canada. So it is good to keep an eye on these, though, and to look them up, again, because they do update. So if you have an old criteria document and you think a drug is not funded, you look 6 months later, it might be on that list. So it's good to keep track of. So as promised, this is the Trillium drug program. So just to clarify, to go into more detail, I think that Trillium is very misunderstood. And unfortunately, it causes harm to people. So the fundamentals, if you're under 65 and you're over 25, you can apply to Trillium and they will pay for your take-home cancer drugs as long as the criteria are met, right? So you have to have EAP approval as well. So you might have a brand new drug that's just come to Canada and Health Canada just approved it and Trillium won't pay for it. So it's because the drug is not publicly funded yet. It's not covered by the government, regardless of your age. So even if you are over 65, they wouldn't have paid for that medication. They might in the future, once the government starts to pay for that drug, but there's a gap. So from the Health Canada approval of a drug to when the Ontario government starts to pay for it, it's usually about 2, maybe 3 years. So you might hear about a brand new therapy and want to access it, and you can't. And it's because the government does not pay for it and may not again for several more years. So it doesn't mean that Trillium wouldn't pay for it. It's not Trillium's fault. It's the provincial government just won't pay for it for anybody. The difference with Trillium accessing ODB is you have to apply for it. So when you turn 65 in Ontario, as of the first of the following month, you're already covered. You don't have to do anything. You'll get a letter from the government and telling you all about it, telling you about your copay and things like that. With Trillium, you're not automatically enrolled. You have to apply. So there's a paper bundle that you can get from a pharmacy or print it from the internet, fill it out, and mail it in. So it is income tested. It is a little bit different. With the seniors plan, when you're over 65, if you're considered a high income senior, there's a $100 annual deductible. It's not that bad. But if you are going on to Trillium, it has a 4% of your net household income deductible. So seniors also have a deductible if they're high income. All Trillium patients have a deductible. And that 4% of your after-tax net income is usually in a few $1,000s for most households. But that's still way cheaper than the cost of the cancer drug. So, which I'll go into more detail, but it doesn't have a cap. That's the only thing. We have people who apply to Trillium. I've had people with very, very low deductibles, and I've had people with deductibles into the $4,000, $5,000, $6,000, $7,000 per year.
Alan, may I just ask briefly, you mentioned that to apply for Trillium, you could download the forms from the internet and fill them in. and send them in. Is this something that the drug access navigator may be able to help a patient with?
Absolutely. So in my office, I always kept Trillium application forms printed out and ready to go. So I could just hand them to people, sometimes 2 copies just in case they, made a typo. But, we could always send a link to it to print out. It's also available at your local pharmacy. They typically will have the forms available. So they are all over the place. It is not made easy. It's only available in English and French. And again, it is paper-based forms. So, they can get lost and dirty. It is cumbersome, but it is a very good program if you need it. So there's a question there.
Alan, yeah, do you mind if I jump in? I'm in that 25, between the 25 and 65 category, and certainly had a lot of help from the Princess Margaret team, sort of sorting out Revlimid and Nilara and all that sort of stuff. The deductible, is that deductible sometimes then also potentially covered by private insurance that you might have? Because I'm not sure. I don't think I pay deductible out of pocket. So are there ways of combining all of those sorts of features?
There absolutely is. So in order to get the most out of these programs, you typically need more than one, unfortunately. Especially with the myeloma, you're probably on an IV drug and an oral drug, or at least 2 oral drugs. So you end up with a combination of different things. But if you're, like for you, because you're under 65 and you need Trillium, you're also probably involved with some patient support programs, which I'll also talk about. And those programs is a big unveil, but for Trillium patients who are going on a take-home cancer drug, those patient support programs from the drug companies will typically pay your deductible for you. So between the patient support program and Trillium, you end up not paying anything for your drugs. So those take-home cancer drugs end up being free, just like the IV drugs for people in Ontario. So that's why there's not like a big uproar that the take-home cancer drugs are not being paid for. They are being paid for. It's not simple. Like if I was in charge of the government, Trillium would be maybe automatically enrolled. Maybe everyone had Trillium coverage and you just didn't use it, or it would be online, or it would be easier. It shouldn't be. The process of getting onto the Trillium drug program should not be so burdensome, but it is. But the problem is, if you think it's not going to help you and you don't apply, you're going to miss out on saving a lot of money. And that's what really I don't like. It drives me crazy when people say, well, I didn't apply to Trillium because I wouldn't qualify. So I've been paying $5,000 a month for my drug. Do you have OHIP? Then you qualify for Trillium. That was the only criteria. So in fact, let's get you onto the Trillium drug program right now. It is very frustrating when I hear that people think they didn't qualify, and then they end up saving thousands of dollars because they ended up applying. So yeah. So I'm going to talk a bit more about the deductible, because that is something that throws some people off. But again, once you apply to Trillium, and you can get access to that same 5,000 different take-home cancer drugs. So this is just a theoretical example. A 55-year-old is applying to Trillium. So their total household income, and Trillium is based on household income, is $100,000. So that's for everybody. The after-tax income, their net income, is $70,000. Trillium is based on your income tax. So the deductible for a family with a $70,000 net income is $2,800 per year. So if you're going on something like some cholesterol lowering medications, $2,800 per year is a lot, and you probably will never get to that amount. You won't reach your deductible. But if you're going on to myeloma drugs, like Revlimid, which like everyone ends up getting Revlimid at some point, right? That drug is $8,500 per month. So your Trillium deductible is $2,800 per year. If you're not applying to Trillium at 55 years old and going on to Revlimid, and you want to pay for it out of pocket, that's a lot of money. That's $100,000 per year that you'd have to pay. if you went and paid for it out of pocket. By applying to Trillium, without the patient support program, which I'm going to talk about, the maximum that you'd have to pay is $2,800. So you're already saving a lot of money on that take-home cancer drug. And again, that applies to any of the 5,000 drugs that the government pays for, as long as you meet the criteria. So that's, again, what really throws people off. I applied to Trillium and they still wouldn't pay for my drug. It's probably because the use of it doesn't meet the government's criteria. And that's a completely different problem. It's not Trillium. It's because there's so many criteria. So with a Trillium, you're saving $99,000 per year for your Revlimid. And that's not bad. So I always tell people, if you're under 65 and you don't have private insurance through your employer, let's get a Trillium application going for you. Well, we don't know what drug I'm going to need. Let's apply anyways. Let's get it done first. And then at least you're into the program. And then if you need it in a few months or later on this year, you've already got coverage. So everyone should apply for Trillium. If you want to take one thing away from this presentation, if you know anyone under 65, any cancer patient, even not the myeloma people, they should be applying to Trillium. It's a disservice if they don't, and it's very harmful. So the other program, which some people hear about, I remember some people would come in and say, a friend of mine's being treated in Hamilton, and they're not paying anything for their drugs, and they didn't apply for Trillium. So how are they getting their drugs covered? Are they over 65? No, they're not. So who's paying for their drugs? They don't have a drug plan through their work either. So who's paying for this stuff? And this is typically the kind of forgotten drug payment system. It's called CCAC, or Community Care Access Center. So they will provide these cards that they kind of make you over 65 for 90 days. So you get that same coverage, that same ODB coverage, the 5,000 drugs, fully paid for 90 days. And this is typically used as a form of bridging. So if you're maybe you only need treatment for a month, something very short term after surgery, but you have to have some sort of a home care service to get this access. So maybe you have a port removal, or you have hydration being given at home. There's a whole bunch of different services that are available through CCAC. If you have any of those, you might be given one of these CCAC drug cards, and then they're paying for your drugs. The best usage would be someone who's getting that while they're applying to Trillium. So some people, when they apply to Trillium, it might take a month or two because they didn't do their income tax, or there could be a whole variety of things that slow things down. They might be given a CCAC drug card during that gap, so they have some coverage until they get Trillium coverage. So you can see you end up with using all these different programs. You end up maybe with a CCO drug, an EAP drug. You're also going out to Trillium, and you also got some CCAC coverage maybe after surgery or something like that. So you end up with a mix mash of all of these different programs being used along the way. So I would say, if I recall correctly, in Canada, about 60% of all of the drug coverage is public. So that's what we've gone through. CCO, ODB, Trillium, CCAC, all of those different things are different forms of public drug coverage. And the other big chunk that covers drugs is your private insurance through your employer. So they have companies that provide this. There are things like Canada Life and Sun Life, Manulife, Claim Secure. There's a whole bunch of these different companies, and they all provide some form of health benefits. And those typically will be like massage, dental insurance, but also drug coverage. So you'll get a drug card typically from these plans. And the way that they operate is that they're not going to usually cover things that the government's going to pay for. So when it comes to an IV drug, if it's prescribed by a doctor and you're under 65 and you have this great drug plan through work, you might try to see if Manulife will cover your IV drug. And they might say yes, but they will also probably say no. So if the government can pay for it, then they will say, no, we're not paying for it. that's something that's covered by CCO. They will pay for it. So when will you use this typically? So it's when the government criteria is not met. So the most helpful thing for private insurance is during the gap from when Health Canada approves a drug to when the government pays for a drug. So during that 2 to 3 year gap, while some new therapy is working its way through the regulatory system, that's when these private insurance plans will typically pay for them. So the private insurance will start paying for these drugs usually within maybe a few months of Health Canada's approval. So if you have a really good drug plan through Sun Life or Manulife, you can get access to these treatments years before somebody without insurance can. So you're kind of jumping the queue and getting access to a new oral therapy or a new IV therapy maybe 2 or 3 years before somebody else. So we would end up with patients in our cancer clinic on a drug and somebody sitting next to them who couldn't get that same drug because one of them has a really good drug plan through their work and the other one does not. So you end up with gaps and some frustration because some people are able to get these things paid for, very expensive, brand new drug treatment, and somebody else can't get the same thing. Typically, when you're over 65, the private insurance plans might cut your coverage off. They might have an option of staying on, but it might be reduced in terms of how much they will pay for per year. And that's because when you're over 65 and you have that automatic ODB coverage, the private insurance is saying, no, we're not paying for your cholesterol drugs and your diabetes drugs anymore because the government's going to pay for that. So we're going to reduce your coverage unless you're willing to pay a lot more for that in your premiums. So it's very important if you're turning 65 or if you're looking at getting private coverage, there was some discussion about that earlier, to really look at the nuances and the criteria. Private insurance is very good at saying no to people. So, and I've dealt with this many times. You might have the criteria of a particular treatment and fill it out and send it into them. And then they will say, what about this other criteria that we didn't have posted on the internet? Do you meet those criteria? And then maybe you don't. So it can be a little bit frustrating when it might look like the private insurance plan will pay for a drug or a treatment. And then when you actually ask them to do it, they say no. They found some sort of extra criteria that you didn't meet. Can be very frustrating. So it is very important to look to see what they cover. Increasingly, there's a lot of plans out there that have very low maximums on them per year. So you might have 100% drug coverage, but it only covers $5,000 per year. So that's fine for cheaper medications that are only a few dollars. But when it comes to cancer treatment, as we just saw with Trillium, $5,000 gets you not even 1 month of Revlimid. So if you have a $5,000 cap on your insurance plan, it's not going to go very far. So I had many patients who I would see with insurance plans through their employer, and we would explore to see if it would be able to cover their drug, and it said yes, only to find out that they only have $1,000 maximum that they can access per year. So in the end, that's not going to help them. Those people end up applying to Trillium because Trillium, as long as you have OHIP, won't say no. So private insurance, I have mixed feelings about. If you have a good plan, it can be very good. It can get you things that you can't get any other way. But if you don't have a good plan and you need it for something very serious like myeloma, it might let you down. So the only way to find out is to call your insurance and talk to them. Is there an annual limit on my plan? Is there a lifetime maximum on my plan? How much does it cover per year? Is it 80% coverage? Is it 90% coverage? I had insurance plans I saw with only 40% coverage. So the people don't realize that until they actually go to the pharmacy and use their insurance and realize it covered almost nothing of my drug. That's not useful anymore, right? So yeah, there's another question. I think you're on mute.
Yeah, Alan, what you're saying is really interesting. I want to get a sense of your role as drug access navigator when you were contacting an insurance company and trying to negotiate this, because I've had very good experiences with the drug access navigator, Princess Margaret. And it seems to me that you guys play a really key role here, as opposed to the patient, in terms of figuring out what even a private insurance company would do.
Yes. So what we try to do, because we deal with these things every day, is we try to navigate it. So what we'll end up doing is, we know we've submitted applications to these companies before. We are a little bit more experienced in terms of what we should say, where to find the right forms to do these things, and also to make appeals. So if the insurance says no, if you get sometimes you might get a letter, it just says, we're not funding this drug, and you might think that's it. But your navigator could submit an appeal to the insurance and say, well, this is why you should cover this drug, right? So they're pushing back. And also, if they do end up saying no, and ultimately you can't get private insurance and you think that's the end of it, they can guide you onto applying for Trillium and help you with that. So a navigator is going to steer you through all the different channels and see where we can get you your drug. So if it's not through private insurance, we'll try them, we'll appeal, we'll push really hard and see what we can submit. Sometimes you have to appeal multiple times. Sometimes if you include additional data, like some clinical trial information, submit that, then the reviewer might say yes. So it really comes down to the policy of the insurance company. Who's reviewing it, unfortunately, can make a difference. A whole bunch of different factors. So it doesn't hurt to appeal. It depends on why they say no as well. An insurance company might say, we won't pay for Darzalex if you're going to get it in a hospital. So, okay, I can't get Darzalex, but it just said in the hospital. But what if I go to a private infusion clinic? Then you can appeal and they say, well, we're going to have this done at a private infusion clinic. Will you pay for it? And then they say yes. So if you didn't have a navigator to steer you through that and explain all of those, what that no really means, you might not end up getting coverage when you could have all along. So they're definitely helpful for those types of things. That's what we do. So the other really critical funding source, I think they're all critical, but especially in myeloma, and I was waiting to get to this, the patient support programs. So when it comes to any of these sort of funding sources, when they have a deductible or a copay with your private insurance, it can be a lot of money. So if you have, say, Revlimid and it's $8,500 per month, and your insurance is covering, say, 80%, that's still a lot of money left over each month. So that 20% copay, you might think, well, I've got my insurance is covering the drug, but I still can't afford it because the copay is so expensive. That's when something like these patient support programs can help out. So they will typically be like the Band-Aid. So you've already applied to Trillium, you've already gotten approval from your private insurance plan. You also need to go into these patient support programs. And if you have any additional cost, they will typically just pay that for you. So they're paid for, these programs, by the drug manufacturers. So if you think of it like you've been prescribed Revlimid or Ninlaro, and you're so close to getting it covered, your Trillium deductible is, say, $2,000 per year, but you can't get it. So the manufacturer does not make a sale. But if they paid just that $2,000 per year, covered your Trillium deductible, they get $100,000 in revenue from you. So they're paying a little bit and making a lot of money. So they put these patient support programs out there to provide financial assistance, because they know if they pay a little bit, the Band-Aids, so they're plugging sort of the gaps out there, your insurance copay, your Trillium deductible, those types of things. They're actually going to make a lot of money still by plugging those small gaps. They would rather pay $2,000 for your deductible or $5,000 for your deductible, because they're going to make $100,000 per year from the sale of the drug, right? So that's why they have these programs. They're very helpful. They're very, very motivated to get you onto the drug. So not only financial assistance, but they'll do all sorts of other stuff. They have bells and whistles, like they'll deliver the drug to your house or to your work, wherever you need it. They'll have, what else do they have? They have basically any sort of assistance that you might need financially, but they're really motivated. They'll help you with contacting your insurance even, right? So if you're in a center that doesn't have a navigator, or you missed out on speaking to the navigator, they'll also help with that. If you're applying to Trillium and it's taken a while, maybe it's slowed down because of some income tax issues, they might give you the drug for free in the meantime. They would rather get you on that drug right away, and then Trillium will pay for it in a month or two, and they'll make sales for years to come from it. Sometimes they'll also provide drugs for free. So this is the really key part. They're great. You should always be enrolled in any patient support program. If you're on a take-home cancer drug and you're paying anything out of pocket, like your Trillium deductible, you should be enrolled into that program for your drug. The programs are per drug, so there could be a lot of programs. So if you're on Revlimid and Ninlaro, then you would be in the RevAid program and the One Path program. So because each program is only funded by the drug manufacturer, they only support their own drugs. So if you're on 2 drugs, you'll end up in 2 programs because they'll each support their own therapy. But they're really helpful if there's a time where you're in that gap between Health Canada approval and provincial funding, and you don't have private insurance. There is a chance that the manufacturer's patient support program will provide it to you for free. So something like Ninlaro, for example, there is no provincial funding for Ninlaro, and they've been trying for a very long time to get funding, and there still isn't. So if you don't have insurance and you're on Ninlaro, it's because the drug company is giving it away for free. And they do that with a whole bunch of different drugs. You just have to be into that program. So just like CCO and EAP and ODB, they'll have criteria. So maybe the drug company will provide the medication for free for a particular group of patients. So it has to be used only in the second line and only with Pomalyst or something like that. But if you meet those criteria, the manufacturer will give you the drug as well for free, or at least until there's provincial funding. So they might give it to you for free until the government at some point in the future starts to pay for it. And then you would transition from the free drug to the government paying for it. So a lot of people were getting Kyprolis for free for a long time because Amgen was giving it away for free. And then eventually the government started to pay for it. So although along from the patient perspective, no one was paying for the medication, some were getting it for free from Amgen and some were getting it covered by the government. The goal is to really not have any difference. Whether you're paying with Trillium or CCO or insurance, ultimately you should just be treated the same as everyone else. And that's kind of what these programs can do. They can help smooth it out. So if somebody has private insurance and get a drug, what about the people who don't have insurance? Well, that's where the patient support program can say, if you don't have insurance, we'll give it to you for free. But if you do, if you can pay, then you have to pay. Hope that makes sense. Now that we've talked about the patient support programs and how important they are, there's still a few more optional funding sources, but the ones that we've gone through so far are the primary ones. That's how the vast majority of people get any of their drugs covered. Those are the dominant sort of programs that are available. Again, it's a mixture of them. So you're going to need, even if you're over 65, you might go into some of these patient support programs for some of the services they offer. For Revlimid, you actually have to be enrolled with the RevAid program for safety purposes, but Trillium, private insurance, like there's, again, it ends up being a mixture of all of those different programs, including the patient support program. And then we get into some of the still important, but less talked about maybe. Oh, sorry, one more about PSPs, and then we'll talk about something else. But so the patient support programs, like I was saying, will cover financial assistance for you. So your deductible with Trillium. So that $2,800 that we spoke about before with Trillium, that patient support program will probably just pay that for you because it's better to pay out $2,800 than lose out on a year worth of sales of the drug. And same for your private insurance. If you are paying a copay for your drug, there's a patient support program available, or at least to ask, because they will probably cover that for you. So if you're over 65 paying for your medication with your insurance, And most insurance don't cover it at 100%. It's usually 90 or 80 or 70%. That patient support program, if there is one for your medication, and most of the cancer drugs do have one, will probably cover your copay for you.
So Alan, it's Dave here. This is something that I would say most likely, the patients wouldn't know about. So it shows the value of having a drug access navigator who is aware of a program like this, particularly the patient support program.
Yeah, so these programs require enrollment by a physician. So very, very few, and none of them in cancer that I'm aware of, you can self-enroll. They all have to go through a doctor. So you probably wouldn't know that they even exist if it wasn't for the navigator and for your physician. Yeah, Jocelyn?
Jan has a question, I believe. If you unmute.
Sure. I'm not sure if it's the right time to ask, but since you went through the drug plan and the private insurance, I thought maybe I should. I'm currently insured by a drug plan through my employer, and I'm told by my employer that it expires at age 65. It's a private sector employer. And this kind of relates to what Doug is going through in terms of research now too. I'm very interested to know whether that is going to roll over into some other type of program where I pay some premium, or whether it fully expires. And is that dependent on what my employer has negotiated with the insurance company? Do some the gold-plated ones do that, and then the ones that aren't gold-plated don't do that? What can you tell us?
So unfortunately, with private insurance, it's all over the place. So with the public plans, because there's just a couple, and it's all very, for the most part, transparent in how you can get onto the program and what they cover and all of that. When it comes to these private plans, they're all negotiated separately with the employer. So even if you have a Manulife plan and somebody else has a Manulife plan, they can be completely different. The only same thing is you both have a card that says Manulife, but in terms of what they cover, the premiums, how much you pay per month, all of that can be completely different. So unfortunately, it's not as simple as, Sun Life does this, or when you turn 65, this will happen. It's very specific to what the employer has decided. Plans like for teachers, for example, they are given an option. There's 2 plans in Ontario where they can choose after 65 or after retirement, at least, where there's a lower tiered plan and a higher tiered plan. So sometimes you might be offered different options. They might have only the one option. But it's very important to see how the plan will change. We often have patients who were switching from one plan to another, and their employer and the private insurer would say it's identical. The new plan will cover everything from the old plan. We were guaranteed everything would be fine. And then we would find out their drug wasn't covered under the new plan. So they might have a list of drugs that are covered, and it looks very similar to the new list of drugs that are covered. But when it comes to certain drugs, you just need one not to be on the new list, and that's your drug. So it's really important to actually speak with the insurer and ask those questions, like what will change? Is the copay going to be the same? Is there any option to pay more? Can I pay a higher premium to maintain my old coverage? Because what usually will happen is if you have, say, unlimited drug coverage under 65 or a very high cap, like $1 million or something, when you turn 65, that will typically drop very, very low. It doesn't mean for sure it will, but that's typically what I would have seen, because the expectation from the insurer is that the government will pay for your drugs. You won't need much coverage anymore because the government will cover most things. Of course, as we've just said, there's gaps. So if you have cancer, the government might cover your drug in the future, or you don't meet their criteria. There's a whole bunch of reasons why the government won't cover your drug. And your insurance was the only way you were getting that covered. So if they cut your coverage down to $1,000 per year, that's going to impact you a lot because you needed that coverage and the government wasn't an option for you. So it's definitely important to talk about that.
Okay, and employers are under no obligation then to continue coverage past age 65. because they'll just say, well, no, you go to the government plan now.
Right. It's a way of keeping their costs down. Everybody on private insurance is a risk, right, of cost. So if they can say our cost now for everyone over 65 goes down, we pay out less because the government takes it on. It keeps the business's costs down. So it's not that they're doing it out of, they're being mean or something, but it's usually just comes down to numbers. And when you talk to employers, they typically don't know any of this stuff that we've talked about today. If you talk to a manager about, or even someone from HR who's negotiating these insurance plans, and you talk about patient support programs in oncology and the gap between Health Canada approval and ODB covering the drug, they have no idea what you're talking about. So unless you're living in the world of drug reimbursement, the people who are negotiating these things, they understand generally and they understand broad aspects of the reimbursement space, but they don't understand how easily somebody can slip through the cracks and not have coverage anymore when their plan does change, because most people are fine, right? Like 99% of the employees, no difference. They won't even notice something happened. But it ends up being the people who do notice are impacted a lot because they might not have access to that treatment anymore.
Thank you.
No, great question. It's very frustrating that we can't provide better answers for that. It's something that it really comes from the employer and the insurer. And even then, so when you talk to the insurer, write down everything they say, write down who you spoke to, because there's been times where I've had patients say, well, I called my insurance and Sun Life said the drug was covered. And then we would actually check and it was not covered. So they might say things to you which are, they end up being true ultimately. So,
can I just ask a follow-up question to that along the lines of what you're saying now? You talk about the fact that there are often multiple submissions to the insurer to request that a drug be funded. And I guess that is through the Drug Access Navigator, but does the patient ever hire a lawyer? Because there are lawyers that do this, they specialize in this. Have you seen that happen? How does that work?
It depends how hard you want to push. So for the most part, when I had a patient who the insurance said no, if we did an appeal, we would that was also a no. We were usually able to find something else, like the patient support program. So we could go to the manufacturer and say, this patient has Sun Life. Sun Life said no. Will you give them the treatment instead for free? And they will say yes, for the most part. Or the insurance said no, and then we went to Trillium. So we usually were able to find an alternative without having to do that, but there's definitely room for that. There are, especially at Princess Margaret, there's very more unique situations where there are no other alternatives. The manufacturer says no, and everything is a no. So that could be a time where you want to consult legal advice to see, but that would also bring up cost. And typically, if you're on these treatments, you might not have the energy and I guess it's a lot to take on as well as having myeloma. So it's not something everyone could pursue, especially if there might be an alternative treatment that your doctor could prescribe. That might be considered equivalent. So there might be an easier option than going through the lawyers.
Okay. Can I ask a follow-up again about private insurance? One of the situations I encountered was a problem with the funding, and I found that there was somebody at the insurance company who actually advocated on my behalf. And I couldn't understand this person's role, but they seemed to have some sort of senior role, and they could go in and clarify the situation. Can you talk a bit about that role?
Yeah, so it really comes down to, it's like when you're dealing with anything, if you call TELUS or call Rogers, and the person you're talking to on the phone won't give you a credit for something that went wrong. But if you ask to talk to their manager, their supervisor, that person is much more experienced and much more aware of the grand scheme of things and how things really work. It really comes down to sometimes the frontline people They're not necessarily involved, don't want to be as involved. When you're talking to those people, they're very, very rarely have any healthcare experience. But when you escalate or talk to somebody higher up, that might be a pharmacist. It might be somebody who actually is a healthcare professional. It could be a nurse, even something like that, or somebody who's been in the industry for a lot longer. So when you ask the question to the right person, you get a different answer. So it's really just like calling any call center. Sometimes you do have to do that, ask for somebody else. This is not going the way I planned. You're not understanding my question. I need to talk to your supervisor, to your manager. And then suddenly things start to click. And then they're like, okay, yeah, we can see here on the form and we're going to approve it, right? So that definitely can happen. It's not, I wouldn't say like every insurance company is going to have like such a clear, simple, if you ask for the manager or something, they're all going to have somebody who can just fix things for you. That's why we do escalations and we do appeals, and you can do multiple escalations and appeals and still be told no every time. Reviewed, even you can have outside escalations and have it reviewed by a physician even sometimes, and they will still say no. So it really depends on why somebody says no. Is it no because the criteria is not met and that's black and white? Or is it no because of something more gray, right? So if you get a no or you want to talk to somebody else, you just have to know what to say, right? That's why you go through your navigator, because they can say on the form, it says no, but we are going to do this. Like there's usually some sort of avenue that you might be able to get around, but it really depends on the reason why. So it's good to inquire to see why, and if there is something else you can do with that.
Doug Clark, you had your hand up, I believe. Did you have a question? Oh, we'll get you to unmute. Yeah, there we go.
Oh, hi. I wanted to mention, Jan was talking about age 65. I've recently been asking because I thought there was some requirement that the drug company had to treat you is the same as they treat a healthy person. No, there isn't a law. It's only what your company's HR department was willing to pay the insurance company. And and fortunately I'm at Hoop, which was willing to pay more to keep a gold-plated plan, probably like OTPP, because some employers, the amount they pay is, they don't care. Because there's so many numbers and so many zeros in what they're investing. So, the answer is that what you want to do is you want to see if you can stay on your employer's group health plan after age 65. I was told it would be about $5,000 a year, but I now know that I have $200,000 coverage at a cost of $5,000 a year. And given the cost of the myeloma drugs, hey, that's a huge bargain. And just you want to see if you can stay on your group plan. And that's what you have to apply for within 30 days of leaving your employer, or they don't have to keep you. So it's very time sensitive. So don't leave your company if you want to stay on your group plan, which I would strongly recommend because it's a bargain, especially for people like us who are taking expensive drugs. Stay on their plan, pay the $5,000. Maybe you can get someone else to pay part of that fee. I don't know, but I'm happy to pay the $5,000 to know that I've got $200K, because let's face it, our government is hugely bankrupt, and I'll stay out of politics, but they're bankrupt. So they're not going to be, in my opinion, they may not be any rush to add new expensive drugs fast.
Yeah, no, I've had that happen myself. I've had them say no, and I asked them why, and they said, well, something was not filled in or not filled in right. And I say, I'm holding the paper in front of me and it's filled in. Can you look again? You're right, it is filled in. And then they would approve it. So it can be dumb stuff like that, but that's why you have to really follow up with them. It doesn't hurt to talk to them. And again, like when you talk to them, write down what they say, who you're talking to, do your due diligence. When you do turn 65, just like you advised, all of this information is out there. your employer might not tell you. The insurer might not tell you that something very important is going to change on your drug plan, and you don't know. If your coverage goes from $1 million per year down to 5,000, I'm sure it's somewhere in the contract. It's in the bundle of paper that they give you to sign, but you don't know to look for that. You didn't know they were going to change it. No one proactively told you, and then you get surprised that, oh, now I don't have coverage anymore, right? So that's typically what'll happen if you're not really diligent. Something could change, and you end up suffering from it. And they're just going to say, well, you signed the form, you agreed to all these things, but you didn't know, right? It's very easy to miss out on little details like that, unfortunately, but they can have a very big impact.
You got 30 days.
Yeah. So that's why you really want to be on top of anything like that. Ask lots and lots of questions. Don't worry about it. Like, just ask anything that comes to mind, or, if you have a navigator available or somebody who could help you, go through that. Like the more support you can get when you do these things, even if there's like a checklist that Myeloma Canada could come up with. When you're talking to your insurance, these are the questions you want to do when you turn 65 to make sure you do that. Of course, the navigator is there to help, but I mean, anything that we can do to, like this education session, anything we can do to make people more aware, to even ask the question, really does go a long way. Okay, so we have just a couple more. Clinical trials is another way of getting access to medication. So you might already know this, but when you go onto clinical trials, typically the medication you're going to be getting is for free. And it's typically going to, not always, but some of the trials will be for drugs that are coming in the future. They're not always future drugs, though. They could be new indications, new ways of using existing drugs that have been around for a long time. So there's all sorts of different types of trials. But what it really comes down to is if the doctor, like if Donna Reese says, we want to get you Darzalex with pomalidomide, and it's not funded and you don't have insurance, but we happen to have a clinical trial for that combination, and we can put you on there and get it for free. So it's not a trial. It is technically a trial. We're trying the drug in a different way, perhaps, but they're not experimenting on you, right? Like there's some apprehension that clinical trials are very risky because the drugs are unknown and they're given barcode names and stuff like that. But there is some drugs where honestly, the drug doesn't have a name. It does just have a series of numbers or letters attached to it. But there's lots of trials as well for existing therapies that maybe just aren't funded right now, provincially or through private insurance. So when you look at clinicaltrials.gov, or presumably your treatment team will have already looked through there, but if you're keen to look and find out what's available, the clinicaltrials.gov database can tell you all the open clinical trials that are going on all across Canada. And you can type in the name of a particular drug, and you can see where the trials are being held. You can see the criteria for the trial. And you could potentially say to your doctor, there's a trial for this drug. Would I be eligible? And they might say no because of other reasons, but it is potentially another funding source available. It's not as easy as going through ODB and private insurance, because with a trial, there are quite a lot of follow-ups. There's a lot of questions that go along with it. It takes a lot more time when you go through a trial, if anyone has participated in one. But the perk is you are getting that medication, potentially no other way of getting it, for free. So it is potentially something to at least consider for something newer. If you're maybe fourth line and there's going to be trouble getting follow-up therapy options, looking at clinical trials to see what's available could be helpful. So the last funding source that we have is called the Special Access Program. So this is something that you might have used. It is through Health Canada. So it's a federal program for accessing medication. The difference with SAP is it's drugs that are not Health Canada approved. So these are drugs that are getting brought into Canada from another country. So it's typically, there's criteria associated with this as well, but they're not available online. It's very case by case. But there's the main criteria is that if there's a drug you're asking for, it A, can't be available in Canada, and B, there has to be no alternative option available in Canada. So for example, if there's a new type of drug, a new class of therapy, like when Darzalex came out or when Kyprolis came out, something that's innovative and new, and it's not Health Canada approved yet. So say it's approved in the United States and you want to get access to it. So because we typically get drugs in Canada several years later than the United States, or sometimes we don't get the drug at all, it might be something that your doctor could apply through the special access program for, and then it could be sent to Canada from the manufacturer in that other country. So it doesn't mean it's guaranteed. You could apply to Health Canada and Health Canada could approve and the manufacturer could say no. So it's not as clear cut. It's very case by case, like I said. But if you are fortunate, if there's a particular drug that you've seen the FDA has approved and you apply to Health Canada with your doctor, the doctor is the one who's really doing it. You're not really involved with it. But if they apply and Health Canada approves and the manufacturer says yes, that medication could be sent to you from the United States, American supply of the drug for free. So it is something that you can keep in mind. I know a lot of people check the message boards and check online, and they might see new drugs that aren't available in Canada. You might think, well, it'll be great one day when we have that available here, but you might actually be able to apply for it and get it in advance. So it really depends. It has to be, again, something that there's no alternative in Canada. So the doctor might apply to Health Canada and they say, but there's Ninlaro in Canada, or there's Darzalex already in Canada, so we're going to reject it. But if it's something newer where there isn't an alternative, you might be able to get it approved. So this is not really a program, but it is something that you can do. Hopefully no one is doing this, but paying out of pocket for your medications, it might come down to that. I mean, theoretically, if you're going on something like cyclophosphamide, that's considered to be a cheaper medication in the oncology space. Is not as bad as Revlimid and some of the others, but even that could be hundreds of dollars per month, but you might be paying for it out of pocket. If you're under 65, or for example, something like cyclophosphamide, if your deductible is more than the price of your drug, you will not derive any benefit from Trillium. It's only for more expensive drugs. So if you need drug coverage for something that's only $200-300 a month, and your Trillium deductible is too high, you end up paying for it out of pocket. So what you can do for that situation is, if there is a patient support program for the drug, then you can be enrolled into that, and they might be able to provide a discount for you. So they might be able to knock off some of the cost at least. So you're not paying the full retail price of the drug. They might be able to sell it at 25% off, 50% off. That's another reason why you might want to be enrolled into a patient support program, at least to see and ask. So it might be a service that they offer, but if you don't ask to see, you should be enrolled and at least attempt it. And if they say no, maybe you can appeal, maybe they still say no, but at least there's that chance that they could say yes and you get a discount on the price of that medication. Anything that could help. So yeah, clinicaltrials.gov, it is American, but all the Canadian trials are on there as well. So if there's a clinical trial at Sunnybrook or Princess Margaret in London, Hamilton, they'll still show up there, even though it's a US database. It's the most robust one to use. So it's American, but it's still good.
I saw Doug with his hand up there.
Oh, hi, one very quick question. The previous screen said, to the arm that contains something that they want else than what they wanted. What does that mean, please? For the trials.
Oh, yes. So the way the clinical trials are already set up, so it's not something that you can ask for a drug for, right? It's not something where you can say, I need Darzalex and I'm just going to go onto the trial and get Darzalex. Because of the nature of these trials, sometimes you might be randomized to not the drug you wanted. So there's always that potential chance. So it's not something that's a guarantee all the time. If you look at some of the trial structures, it will typically be one drug versus another drug. And the intent is to see which one is better, or 3 drugs, right? So the intent is over the course of several years of having these 2 trials, of this trial run with these 2 drugs, we want to see at the end which one was better.
Does that mean you might get a placebo that has no medical help?
So they typically don't do placebos in cancer care. It would be a drug versus a drug. So instead of getting a drug versus sugar water, it would be maybe the drug you wanted versus another drug. So it's something very careful when you're looking through the criteria, and your physician would be, of course, looking through this very thoroughly. But if you're looking yourself and you see on clinicaltrials.gov that there's something out there, to look at what the comparator arm is. So it's the drug I want, but what is it being compared to? Because I might end up with that other one, right? So you have to really look and read it. It's a lot of text to go through, but it is something, if you are ever looking at clinical trials, just to be aware. Because if you are enrolling, theoretically, and what they'll do is randomize you. So no one necessarily knows, the physician may not know, or the researcher may not know which drug you're getting. But you might not get the one that you had hoped for. But not sugar water, but you would be getting something else, another treatment.
Right. It depends really how I'm currently on a Darzalex trial, daratumumab, and it's structured such that what they're intending to do is determining the adequate or the appropriate dosage. So
yes,
everybody gets daratumumab. There is no control group.
Those are the trials you want.
Right. Yeah. Exactly. So there are those trials.
Yeah. So the single arm trials, those ones are guaranteed. So it's going to be, like you said, it might be the drug given in a different way, a different frequency. So maybe the drug is given every 3 weeks versus every 4 weeks, but everyone gets the drug. So if you see a trial and it's just the one drug, there's no comparator drug, then you are guaranteed that treatment. But it is just to be aware, if you see a drug listed in the trial, is there a comparator arm, right? And if there is, what is it going to be?
I have a question.
Yeah.
Is there a way to get help from a drug navigator if you're treated in a hospital or a center that they don't have a navigator or reimbursement person?
There should be one at all of them. So if you are being treated at a hospital that you haven't seen the navigator, it might just be that they haven't referred you to them, but they should be one at all of the centers, at least in Ontario.
Any place in Ontario, no matter what?
Yeah, any of the cancer centers do.
Okay, if you are treated by hematologists, that is not necessarily in a cancer center as well?
So that's a little bit of a different problem. If the doctor is associated with a hospital, like if they also practice out of a hospital or also see patients at a hospital, I would ask to see the navigator at that hospital. But yeah, that's a little bit of a gap. What you could do is there's a group of navigators in Ontario. They have an association, which I'm going to highlight later on, but it's called Odano, that Dave mentioned. So if you go to odano.ca, you could message them. And if you have a particular concern, they might be able to either point you towards a navigator, or depending on what the question is, they might be able to help you through that. It's just not ideal.
Mm-hmm. I understand. I am treated at Princess Margaret, and everything you're telling me here, you're telling us today, for me was kind of like behind the scenes. I didn't even know that that's what's happening. I know the person I know the reimbursement drug specialist, but I didn't know that she does so much for me.
Yeah.
I just want to make sure that if someone asks, if there's anyone who's asking, either in Ontario or somewhere else, we can tell them how to reach out to all those amazing platforms.
Yeah, well, my last slide actually, just before the thank you, is some links. So
great.
definitely you can direct them to those websites, and it's better than nothing. It's best if you're at a place with a navigator, but if you're not, the websites do help. At least they do steer people in the right direction.
Alan, there was a question earlier in the chat about what kind of programs perhaps exist in Quebec, if you're at all familiar with some of the other provinces around Canada, and what access we might have, nationally.
Yeah. So because healthcare is administered provincially, every province is so different. There are navigators in Quebec, though, so they could help with things like RAMQ. RAMQ is the same as ODB, except for Quebec. The patient support programs are typically the same across Canada. So if there's like the RevAid program could support somebody in Quebec as well as Ontario. So there's a lot of the federal things, SAP here, clinical trials, those are the same across Canada. But for the provincial programs, there are people who can still support them in their clinic in Quebec. Same with the Maritimes, same with Alberta and everything. Ask to see if there's somebody like a drug access navigator or somebody who deals with reimbursement, or to talk to the oncology pharmacist. That's kind of like they all kind of dabble in medications, so they can at least help answer most questions.
Mm-hmm. Alan, it's really encouraging what you mentioned there, that essentially all the community hospitals in Ontario who treat cancer patients would have a drug access navigator or access to one. And that's great news, because I believe a few years ago, that was not the case.
No, yeah, that's true. Yeah.
And it's still not the case in many other provinces in Canada.
Yeah, so I actually do work with the navigators in the other provinces, and there's not nearly enough of them. So I think there's maybe 15 or so in Quebec, but there's probably room for 40 or 50. So they are kind of like what we were in Ontario maybe 10 years ago, where the role was still taking off. I hope at some point they all have a navigator. In the Atlantic provinces, they mostly do as well. They mostly have a navigator, but you get some of the centers, like if you've gone to Princess Margaret, there's I think there's 5 now. So at some of the hospitals, there's only 1, where there could easily be 3 or 4. So that's another reason why you might not see a navigator, is because they only see certain patients. They don't see everybody, even though that would be great, because there's only 1 person, when there could be plenty more room for plenty more. Okay. So just to summarize really on the Dan helps with all of those things, not really with clinical trials, but when it comes to Trillium, when it comes to private insurance, paying out of pocket, SAP, all of that stuff is what your navigator at the hospital is helping with. Hopefully behind the scenes, the intent is you don't know what they did. Like when Marianne at Princess Margaret is successful, you just have magically, drug appears and there was no bill, right? But she did a whole bunch of stuff you didn't see. If we're successful, you kind of you don't know what happened. You don't see the wizardry that went on behind the scenes. Our intent is that you shouldn't have to think about that. The navigator role is so that you don't have to worry about those things. You don't have to make those phone calls and fill out those forms unless it's necessary. So you're only involved hopefully when your signature is needed, or something went wrong, or your drug's been approved. But ideally, the bulk of the work is going on behind the scenes, and it just looks like magically the drug was approved and everything was great, right? That's what we want. You're supposed to just be able to focus on your myeloma and not worrying about those hoops, right? Leave that to your navigator. So there's a whole bunch of different programs, and unfortunately, there's some common themes. And if anyone wants to be advocating to the government and speak your mind, these are some of the things that I would recommend. Some of the problems that a DAN faces is the same as what impacts the patient. So when you're applying to Trillium, it's slow. It is not a quick process. It's paper-based. You submit the forms, and usually in about a month, you'll get an approval. That's best case scenario. It can take longer than that because Trillium is based on your income tax. And if everyone in the household didn't do income tax, it can take even longer. Same with SAP. You're submitting these forms to the government and you hope that it's approved quickly. If you need it quickly, SAP is not the right avenue to go to because it is going to be slow. Those prior authorization forms for private insurance take a very long time. Some of the insurers are very fast. You can get approval in a couple of days. That's ideal, but there's plenty of times where it will take 2 weeks, 3 weeks, 4 weeks to get an approval from your insurance. And that's if they approve. If there's a rejection and an appeal needed, it can take even longer. The drug criteria for private insurers, even for the government sometimes, is not necessarily clear. That can be very frustrating. If you submit a prior authorization to your insurer, hoping that it's approved, and then you find out the criteria were not met, the criteria were not on the form, how are you supposed to know that there were these secret criteria? It can be very frustrating. You just wasted several weeks of time trying to get this drug, and all along it wasn't going to be approved. So that can be very frustrating. Everything is paper-based too. All the prior authorizations, the Trillium forms, SAP, everything is paper. Everything is faxed. Some of the forms are faxed multiple times. They get ink damage on them. Things can become very grayed out and you can't read them anymore. So it's very easy for somebody to receive the fourth copy of a fax and say, I can't read it, and or I'm reading it wrong, and things can go wrong from that. So the fact that so many things still use fax machines when you could just use email or other forms of transmitting these papers is very frustrating. And again, it can cause miscommunications, misunderstandings, and rejections that are wrong. And this is especially important in myeloma, but in some of the other cancers, you're on one drug and that's it. And that's enough to deal with. But in myeloma, you're very rarely on one drug. You're on always at least, dexamethasone is thrown into everything. So you're always on 2 drugs or 3 drugs or, 4 drugs sometimes. It can be, you're on a whole cocktail of different things. So when it comes to reimbursement, you have to do all the forms for all the drugs. So when it comes to prior authorization forms for somebody going on triplet therapy, you could have to submit all of those, a form for each drug. And if you have a spouse with insurance, you do it all again. So you could, for a triplet therapy where you're submitting prior authorization for a patient and their spouse to the insurer, you can do 6 versions of everything. That's a big pile of paper and it can very easily have something go missing, a single page, or again, faxing all of that and something going wrong along the way. So you're basically set up for, you're asking for a problem when you have all of these different forms going to all these different places for all these different things. And that's kind of most frustrating, I think, the paper-based, the slowness, and faxing everything. If we could get rid of these, I think that there's still a lot of problems, obviously. It would be great to get rid of the Trillium deductible completely, especially for cancer patients. If you have cancer, you shouldn't pay a Trillium deductible, in my opinion. Everyone else can pay them maybe, but not the cancer patients. If we got rid of these low-hanging fruit, I think our healthcare system would be at least a step in the right direction. But again, these are just archaic things that they deal with in the hospital every day. And just lastly, the universal pharmacare, which is, if anyone's following what's been going on with that, just to really summarize what it could theoretically be like if we got pharmacare next year or in 2 years or whenever it ends up happening, there would be a national list of all the drugs. that are funded and the criteria. So just like that CCO and the ODB criteria, the EAP criteria, it'd be one for all of Canada. So there wouldn't be the RAMQ criteria in Quebec and the Ontario criteria for Ontario would just be one master formulary for the whole country. There wouldn't be any deductibles. So there wouldn't be a Trillium deductible. And theoretically, they're talking about removing private drug coverage altogether. So everyone would just get the public plan. So you could think of it like everyone across Canada would be treated like a senior in Ontario. There would be no private insurance, though, to go along with it. So there would be no deductible. Everything would just be covered. But there's a lot of problems with that, too. As you know, the government is not always picking up drugs quickly. So we use private insurance to access those drugs in the gap. But if there's no private insurance to cover your drugs, that gap applies to everybody. So there's definitely some benefits to having one list of drugs, one list of criteria for everybody, but you're also sacrificing your private drug coverage to access treatments early. So there's some downside. There's also a push towards more biosimilars and generics. So there would be a lot less usage of brand name drugs if there is a generic out there. So the public plans typically will do that. But if you have private insurance, they may pay for brand name drugs and you might be able to stay on brand name drug. Whereas if you have national pharmacare and everyone's on the public plan, there would be probably no more use of brand name if there's an alternative. So there's some thoughts about that, about not wanting to switch to a generic or a biosimilar if you're doing very well on the brand name therapy, even if the generic or biosimilar exists. But if we had national pharmacare, you might be forced to switch. So definitely some things to keep in mind. If you follow drug reimbursement as closely as I do, this is something I do think about quite a lot as to how it's going to play out. It will affect everyone if it does come to fruition, but we'll see what it looks like. So just the last thing, as promised, if you're curious about drug reimbursement in Ontario, the Navigator Association here, Odano, is at odano.ca. The Quebec Navigator group is the acamo.ca, and Atlantic Canada also has one. So they call themselves the Atlantic Canada Oncology Drug Access Navigator Association, and they're at acodana.ca. So if you have any friends or family, if you know anyone with myeloma or any type of cancer in any of those regions, it is helpful to go onto those websites. They do have a lot of interesting tips and tricks, information on how to reach a navigator, your local navigator, all sorts of useful information.
I think Doug has a question there, Ellen.
Yeah.
Oh, hi. A very quick question. You explained how lots of these drug-paying organizations can take a long time to process them. And as you all know, time is everything with us, and we can't afford to wait. Sometimes you can't afford to wait a month or two or more. If one said, "Hey, I'm going to get reimbursed for this. I'll pay out of pocket now, and then they'll reimburse me later," would that happen or not?
So that depends who's paying. So if you're applying to Trillium, on the enrollment form, you can select your start date of benefits. So if your start date is today and you apply and you're paying for your first month out of pocket, you can get that money back because your benefit started today. But if it comes to a private plan, or it comes to a patient support program, it's more of a case by case. So you're not guaranteed to get the money back if you pay out of pocket while waiting for your prior authorization from your insurance to go through. It might be when the approval comes through, it could say we're backdating at 90 days, and that would be great. Or it might say your coverage kicks in as of right now, and you've already been paying for a month or two. So it's not guaranteed. And that's another reason why, if you are thinking about doing that, to speak with the insurer upfront and clarify. It's not always fun talking with insurance, but if you're going to fork out a lot of money out of pocket, you don't want to do that and risk potentially not getting it. The alternative would be going to the patient support program. So if there is one, One of the services they offer often is bridging supply. So they might give you a month or two for free until the insurer or Trillium or whoever pays for the drug. And then they're the ones who are forking out the medication. And then the rest will just be covered by that payer, and you're not out anything.
Thank you.